Well, in this week's Cardiology Countdown, dare we mess with QT prolongation? What about troponin post-op in non-cardiac surgery? And finally, platelet reactivity and prognosis and treatment. So up first is a paper in JACC that looks at the NOS1AP gene and some polymorphisms that may help predict long QT syndrome. The group looked at a group of patients, 58 patients with long QT syndrome and controls in the drug-induced arrhythmia risk assessment, or DARE, that tried to identify novel genetic markers that might help predict those patients who go on to have drug-induced long QT. And they in fact found several polymorphisms and then validated this in other cohorts in the British genetics of hypertension study. And so looking at different cohorts, they were able to identify this NOS1AP gene that could potentially help predict which patients would go on to have the feared drug-induced QT prolongation. So a fascinating study looking at pharmacogenetics to, in this case, predict risk. Next up is a study from JAMA that looks at troponin in post-op evaluation of non-cardiac surgery. This is something we get asked to consult on of patients going on to surgery. And they studied 15,000 patients and looked at all the baseline clinical factors: prior coronary disease, peripheral arterial disease, known stroke, etc., diabetes, and then looked at the post-op peak troponin and found that it was the strongest predictor of 30-day mortality. They found a gradient that went from 1% mortality all the way up to 17% based on the troponin T level measured in this study. And so as such, this becomes a very simple routine measure to try and help identify those high-risk patients that may then need more careful monitoring and treatment post-operatively to prevent mortality. The top pick this week is from the ISAR-REACT 4 study, looking at high platelet reactivity following clopidogrel treatment as a predictor of outcome, but also gave a twist to look at what antithrombotic regimen would be optimal. Now, this study overall studied about 560 patients that compared a regimen of bivalirudin alone to abciximab and unfractionated heparin. Overall, they found equal outcomes and less bleeding with the bivalirudin strategy, validating that seen in acuity and prior studies. But here they looked with platelet function tests and found that the patients with high platelet reactivity post-clopidogrel loading did in fact have about a 50% higher risk of cardiovascular death, MI, or need for urgent target vessel revascularization. And that was in the abciximab group. In the bivalirudin group, those who had high platelet reactivity had a 5-fold increase in the primary endpoint. 22% of those with high platelet reactivity treated with bivalirudin versus 5% for those with low platelet reactivity. That is a good response to clopidogrel. And there was a significant P interaction there. And so it suggests that for those patients that look like they're clopidogrel resistant, using a second antiplatelet agent, actually third, on top of aspirin and clopidogrel, is probably a way to optimize outcomes. And so a nice link between doing something differently based on the platelet reactivity testing. So for this week's Cardiology Countdown, I'm Chris Cannon.